Okay, we're gonna go now. Okay, we are live now. So at the beginning, we are very happy to welcome six of distinctive speakers. Prof. Ihab from Egypt, Prof. Karl Klaus from Belgium, Prof. Nicola from Lebanon, and Prof. Ramzi from Turkey. Also, our dear Dr. Khalid Al-Sabti from Kuwait. Our talk is going to be about the macular surgery, different opinion, many videos, and tricks. I think this night we will learn a lot from a very distinctive speaker. And we would like to welcome all the attendees on the Zoom and on the YouTube. And our first speaker will be Prof. Nicola. You can start your talk, Prof. Nicola.
Good evening to you, Dr. Gahtani, and to all the panelist speakers. And I really appreciate your invite for me to participate among such distinguished speakers who are dear colleagues and friends. I'm going to start off the webinar with two rather infrequent scenarios of macular pathology, unlike probably the subsequent talks, which would discuss rather more frequent pathology and how to approach it from different angles. And I would like to start by announcing that I have no financial disclosures. And I will start off with a case of massive submacular hemorrhage in a patient with neovascular AMD. That's an elderly patient who presented with acute loss of vision in his right eye of few days duration. And as you can see here, there is a large submacular hemorrhage that bypasses the arcades and even reaches the inferior equator. And the patient had bare counting finger near face vision and was complaining of a tense scotoma. And if he closes the contralateral eye, he cannot ambulate with this eye. The symptoms started a few days prior to presentation, and on OCT you can see the vitreous hemorrhage and the large subretinal hemorrhage. We discussed the treatment options. As you know, this is a rather devastating complication of neovascular AMD. There's really no proven treatment for this condition, but there are several reports of successful displacement of the submacular hemorrhage using different techniques. The technique I chose to do for this case was pneumatic displacement of the submacular hemorrhage, and I'm going to share with you the video now. So we start off by removing the hemorrhagic vitreous, as you can see over here. Then the hyaloid is peeled as usual. It's easy to visualize the hyaloid in these cases because it's stained with blood already, so there is no need to stain it. You can see the point of breakthrough hemorrhage here, the fresh preretinal hemorrhage overlying the subretinal hemorrhage. And then here you can see the large hemorrhage. You titrate the rate of subretinal fluid injection. I'd like to see one drop coming out at a time. And I inject about a 0.5 cc's cocktail made out of 0.4 cc's of TPA and 0.1 milliliters of Avastin. And then we choose an avascular area and we inject into the clot away from the fovea very slowly in order to avoid a full thickness macular hole formation. You want to bathe the whole clot with the fluid cocktail, as you can see here. And in these cases, detach the inferior retina so that the blood can displace inferiorly. Then here I'm adding subretinal air, which is a technique that was described by Tamer Mahmoud. The aim of the air is to decrease the buoyancy of blood and help displace it inferiorly into the inferiorly created bleb. You can see here in a little bit that the blood has already been is already being displaced by these maneuvers. Now you can see here that there is the subretinal air can reach the aura sometimes, and hence the value of air fluid exchange. I do exchange about 50% of the vitreous cavity with air, and then I replace that with a long-acting gas, typically SF6, in such cases. You want to fill only 50% of the cavity because you want to trap the air bubble in the macular area where it should act. And this is the end of the case. You can see on the first day post-operatively significant displacement of the hemorrhage completely out of the macular area down beyond the equator. And here is the pre-operative OCT and the post-operative OCT. Remarkable improvement. This picture in particular was 6 months after surgery. The patient improved to counting finger 4 meters. It's not a huge visual acuity gain. However, the scotoma was much smaller and lighter, and the patient could ambulate with this eye when the fellow eye was closed. I would like to touch a little bit on why do we use this technique. And to do this, we have to understand the forces that act on the subretinal blood and its mobility in the subretinal space. There are 3 types of forces. Only one, which is the force of gravity, acts in our favor, whereas the friction and the force of buoyancy, they act against us. And we have to minimize the forces of buoyancy and friction and improve the force of gravity. And by injecting subretinal TPA and fluid, we decrease the force of friction because we lyse the fibrin clot, and we also bathe the clot with fluid, minimizing the friction between it and the photoreceptors and the subjacent RPE. Then we put the gas, 50% gas fill, which improves the force of gravity. And also we position the patient upright following surgery, which also improves the force of gravity. And finally, we inject air into the subretinal space, and the buoyancy of blood in air is 830 times less than that in fluid, which also helps in displacing the subretinal blood inferiorly. Regarding the issue of buoyancy, I made this video for you just to show you the difference. On the left, we have a cup that is empty, meaning full of air, and on the right, a cup full of water. And notice the difference in the movement of ice cube in each of the cups. On the left, the ice cube goes straight down, whereas on the right-hand side, you can see the buoyancy force, which prevents the ice cube from falling down and even lifts it up. So we want to minimize this buoyancy force. So that's the end of my first case. And the key points here are really patient selection. That's the most important. You want to treat patients who have massive subretinal hemorrhage, typically reaching the arcades or beyond. You want these patients to have a good baseline visual acuity, no pre-existing geographic atrophy or scarring. You want a thick hemorrhage involving the fovea, and you want it mainly subretinal, not sub-RPE, even though sub-RPE components can improve with these surgical techniques. Timely management is very important. You want to interfere within a week. Studies have shown that by 1 week and after, significant damage to the outer retina has occurred. And also, the fibrin polymerizes and becomes difficult to lyse. So you want to interfere within a week, ideally. Meticulous surgical approach is also important as described. You want to address as many of the subretinal forces as possible, again, as I described. And most importantly, this is an ever-active disease. Removing the hemorrhage is not the end of the story. You need to control the activity of the CNV post-operatively. And these patients frequently require anti-VEGF therapy after surgery. My next case is a case of macular pucker associated with an RRD complicating congenital retinoschisis. A 34-year-old man who presented to us after having lost his vision in the left eye since childhood. And you can see here the significant changes explaining the poor vision. He complained about metamorphopsia in the right eye, and you can see that he has a significant membrane, epiretinal membrane, along the superior arcades and outside of it, causing the puckering and pulling the fovea upwards. If you look inferior, you see the inferior retinal detachment with large breaks in the outer retinal leaflet and the veil vessels and a degenerated inner retinal leaflet. The OCT was not bad and the vision was not bad. So the patient was not really in favor of having surgery, and he decided to wait. But with time, the vision got worse and the puckering got worse. So pars plana vitrectomy was performed. And here is the video showing trimming of the hyaloid peripherally after removing the hyaloid, the core vitreous. You can see here that the hyaloid is adherent to the degenerated inner retinal layer, inner retinal leaflet. And here are the bridging vessels between the outer and the inner retinal leaflets. These need to be cauterized in order to prevent any post-operative hemorrhage. These vessels are really the only thing that is left of the inner leaflet, which is almost completely degenerated. And I like to cauterize them completely, not only in the place where I decide to cut these vessels. And notice how tethered these vessels are. They're really completely tethered and they're on traction. And I think they're pathogenic in the break formation in the outer retinal layer. Notice that the breaks are at the bases of these vessels, where the vessels insert in the outer retina. At each insertion, almost, you can find a break. You see how they are tethered and they're causing traction of the outer retina. So the breaks are marked, the vessels are cauterized, and then the margins of the schisis also. I like to confirm the absence of any residual hyaloid by injecting triamcinolone. And then here is the pucker being peeled gently with a Tano scraper tangentially. And then once an edge is created, again, the same maneuver, tangential, gentle peeling of the pucker of the macular area. You can see it better here with wide angle viewing after it has retracted peripherally. And you peel as much as you can gently, because again, the underlying retina is a diseased retina. It's a dystrophic retina, not a normal retina. So the key here is gentle, tangential peeling. And then after that, look how the vessels retract when we remove the inner retinal leaflet because of traction. So when the inner leaflet is that degenerated, I would advise remove complete excision of the inner retinal leaflet. And once this is done, then the rest of the surgery is straightforward. It's just flattening of the outer leaflet with air fluid exchange, and then performing endolaser. The schisis margin is barraged from aura to aura, as you can see here with scleral depression to the aura, and then the outer breaks are barraged by laser. So this, the patient did well as far as the retinal detachment is concerned, but then a few weeks later, he developed recurrence of the macular proliferation. You can see the thickening on OCT and the epiretinal membrane. This was again peeled, and he never recurred after that. And you can see the improvement in retinal thickening. Unfortunately, he developed schisis, which was not as apparent preoperatively. However, with the topical carbonic anhydrase inhibitors, the schisis improved, and he became 20/50 and was happy with the outcome. So I'll close by this slide. The key points here are, as I mentioned, tangential and gentle epiretinal membrane peel. Remember, this is a dystrophic retina that lacks retinoschisin, which is important in intercellular adhesion. So the idea that I battled with the most in this surgery was whether the ILM should be peeled or not. And as you know, the ILM represents the footplates of the Muller cells, which sandwich the retinal layers together. So I didn't want to weaken this dystrophic retina even more by peeling the ILM. This was my personal approach. There is no literature on that, whether to peel or not to peel the ILM in retinoschisis, no definitive literature, I should say. But I elected to keep the ILM. The inner retina should be excised if degenerated, because I believe it's pathogenic in the mechanism of outer retinal tears and retinal detachment. Target the outer breaks and avoid bleeding, and use a lot of cautery like I showed you. And thank you very much. I appreciate the invite again. And I'm happy to take any questions.
Thank you very much, Prof. Nicola. Very nice cases and presentation. We have some questions actually regarding the TPA that you are using for the first case. Do you use it? Do you inject it intravitreally or subretinal?
You know, subretinal actually.
Because
so the whole cocktail, the TPA, the Avastin, and the filtered air are all injected subretinally. The concentration. Go ahead.
Concentration.
Yeah, the concentration that I use is 12.5 micrograms in 0.1 milliliter of TPA. The idea is you don't want to get over 50 micrograms. This has been reported as a threshold for retinal toxicity. Some reports report the tolerance up to 100. I use a maximum of 50. This gives me 0.4 cc's. And then I add to this 0.1 cc's of Avastin, exactly like was described by Tamer Mahmoud. And this gives you a total of 0.5 cc's. And with these large hemorrhages, you really need all the volume you can to allow for effective displacement of the blood inferiorly. And then the issue of the subretinal air for the buoyancy.
Okay, regarding the second case, he was having like a retinoschisis, which is also given an image of chronic inferior retinal detachment. Do you agree in the second?
That's true. Yeah. That's true. Actually, in both eyes, I think in the left eye, he had a self-resorbed retinal detachment related to his schisis. There was lots of subretinal bands, significant pigmentation, even in the macula. And in the right eye, he had a chronic retinal detachment. And actually, it was in the past barraged by laser by someone else before he came to see me. And the retinal detachment looks stable. He really came complaining of the macular disease. And this is why I decided to present him in this forum, which is macular surgery. His main presentation was metamorphopsia, but then later on the vision decreased and we decided to interfere.
Last question, which is just knowing your preference. If you have inferior retinal detachment and it's still active, what's your choice? Heavy silicone, banding, or 180 inferior retinectomy?
No, actually, in this case, I use, for example, gas C3F8, non-expansile C3F8.
This is because it's stable, but I mean, if it's acute.
Yes, I still use gas. My preference is for gas. If I can avoid using silicone oil or a scleral buckle, I would do that. Now, with I'm a strong believer in the value of scleral buckle, but in the era of wide-angle viewing, when I'm able to shave completely the vitreous and I feel comfortable that I relieved all the traction, removed all the vitreous, then in these cases I don't use a buckle.
And
I don't
maybe the gas is wise because it's expandable. But silicone, either if you choose to put silicone, I think you have to fill properly the eye and make sure the eye is really full so you can tamponade the inferior detachment. What do you think? You agree?
Yeah, with positioning, if you're sure that you removed all the traction and you position the patient to the side or face down, then the success rate with gas is pretty significant. It's pretty high. I still prefer to avoid using silicone if I can, so that I don't guarantee the patients another surgery. So if I can get away with gas, it's still my preference. Now, if for any other reason you have to use silicone, either height or flights, etc., then I would use silicone, and I would use heavy silicone in these circumstances. Heavy silicone oil.
Thank you very much, Prof. Macular, and we will have discussion at the end. We will shift to Prof. Ihab for his talk.
Good evening, everybody. I'm privileged to join you all in this discussion, and I will focus on the management of failed macular holes. My discussion will be more of an introduction to the next talks, including the rest of fluid in between. In real life, this is a patient that already had a vitrectomy and eye lamp peel. I use the 38 gauge cannula again to go directly from the trocar cannula over the hole. Just go to air, and under air you aspirate the last bubble right here. You have to be over the hole, you don't go through. Engage the fluid as much as possible, and the tip has to be much smaller than the size of the hole. You don't want to touch the edges of the hole, neither the RPE. Gradually, when you aspirate, the hole starts to recoil, becomes smaller and smaller. With a little bit of time there, it starts to recoil, and you can see it on table getting smaller and smaller there until it closes. And you might see it, this is the beginning of the case, and later on at the end of the case, the hole closes on table. What do we do with amniotic membranes? We're trying to cover the hole. This is a patient that had a failed macular hole, and you can see that we prepared the amniotic membrane by taking a 1.5 dermal patch. Usually these are larger than the size of the hole, and you have to trim it. But since the patch is 1.5, usually I like taking it as it is inside the eye. I don't use forceps. If you use forceps to grasp it, sometimes you crush it. But what we do is we use aspiration. I aspirate it in a needle here, so it's a rounded flap. Then you inject it inside the eye, and you can see once it's injected, usually it's larger than the size of the hole. If you have a small hole like this is an 800 micron, then usually 1.5 is too big. So sometimes you have to even trim or resize the size of the amniotic membrane to the size of the hole once you compare it inside the eye directly. Then you take the patch that you need to put it inside there. Here I did it under fluid, but it's much easier doing it under perfluorocarbon because it's more stable. Then you put it over. You don't attempt to push it inside or underneath the edges. I'd like to keep it there. How do you keep it? At the end, I just put some platelet-rich plasma or serum to stick it in place and remove the rest. This is the plasma right there. Then you remove the rest of the amniotic membrane. Then you go to air. This helps the patch to stick in place, and we'll show at the end complication how these patches might migrate even the first day or two. Once it's in place, you can see it here. It's right in the macular hole, and it stays there. This is taken in 2 days. And if you compare that same patient after 2 months, the amniotic membrane is still there. We've seen patients that amniotic membrane stay there for even up to 8 months, which is sometimes more than you need. So the question again is, do we need something to be interfering with the whole healing here? This is a question which I always ask the panel to discuss that. And we're doing patches covering things like that. Do we need something inside the hole, or does this interfere with the normal healing process that we should see in these holes? And this might be a last option for really large macular holes, other than the rest of the techniques that we're going to see during the presentation. I won't see this last case. Maybe we'll show this, Abdullah, during the complication session. So I'll stop here and let the rest of the panelists share their own videos on ILM and the other options that we have on macular holes. Then we discuss that at the end.
Thank you, Prof. Ihab, for this is nice video and presentation. We have a question. Is there any trick rather than the plasma precipitate? This has to be done from the blood sampling of the patient himself. We agree all of that. Have you tried the visco, for example?
Yeah, visco usually doesn't stay in place. And when you put these membranes, you put the best thing is to put it underneath perfluorocarbon. This gives you the option to cover it. But the trick is once you go to air and start to aspirate the perfluorocarbon, amniotic membranes usually tend to shift if they were not in the holes. So that's why there's a lot of surgeons that advocate putting it into the hole. This keeps it trapped. But if you go just over the hole, if you don't use the right side, and I don't think that if you put it on either side, it makes a difference in healing, but it might stick, and I'll show that in the complication videos at the end of the talk, how it sticks to instruments if you use the other way around. But regarding putting it on the hole itself, there is no way you can guarantee which surface it is. So the trick is, again, looking when you start going to air is always look at the amniotic membrane. You might do it bimanually, keep the amniotic membrane in place while you're aspirating the last bit of fluid.
What about push the edge of the amniotic membrane under the rim of the macular hole, under the lip of the macular hole?
Personally, I don't like to interfere with the normal repositioning between the photoreceptors and the retinal pigment epithelium. I feel that this is an abnormal healing process. And we've seen amniotic membranes to last up to 8 months or even more inside. So imagine that you are interfering with the healing between the photoreceptors and the retinal pigment epithelium for that amount of time. So I personally think it's just a patch. You cover the hole until it dries up and the normal healing process happens underneath it. But if you attempt to put it underneath, either you're damaging the retinal pigment epithelium or the photoreceptors, or putting something between the normal healing process.
And you use gas or tamponade in those cases most of the time, or?
Short-acting gas, sulfur hexafluoride is more than enough. And let's think about it, that the macular holes usually close within the first 48 hours of life. So the sulfur hexafluoride is more than enough. Sometimes if you have a small hole and you're sure about the patch, you can even use just air.
Thank you very much, Prof. Ihab. Now we will shift to Professor Karl Klaus from Belgium. Prof. Karl?
Yes, hello, Abdullah. Good evening, everybody.
It's a pleasure and honor to have you this night with us.
Thank you. It's a pleasure for me to participate in this well-attended webinar. So I will be speaking about large macular holes and another option, what I call retinal relocation, to treat these macular holes. I have no financial disclosure concerning this topic. And The treatment actually is for large holes. This means myopic macular holes, failed macular hole surgery previously, and very large holes extending 750, 100 microns up to 2000 microns. We know and we heard already from EHAB, there's different methods to heal the macular holes. I'm not going to go into all of them, but we can just inject the pneumatic tamponade with TPA, as I did in the first case, and which gave an excellent result. Also, just with air tamponade, we can close holes even without positioning the patient post-operatively. ILM flaps to cover the hole are very popular, and this is a loose flap that is folding over the hole. This hole has been closed perfectly after the surgery, but the flap is still free floating, and patient can actually notice this flap in certain moments. In large holes, since many years, I use silicone oil in combination with a special technique that I will mention soon. Very large holes, this is one of 1100 microns. We use the free retinal graft, and as we see, the grafts can be incorporated excellently with the restoration of the cost lines, but also this is not the topic. Previously, we thought it's important to have the right U configuration to get good visual recovery, but now we know that in the deeper layers of the retina and the ellipsoid zone, the most important recovery possibilities are present. So among all these different techniques, actually, which is the best technique for your patient, or which can give the best results? So the aim is to approximate the borders of the macular hole as soon as possible after and even during the surgery. We know that glial proliferation from the free Muller cells worsens visual prognosis. And we aim for a homogeneous reflectivity from the ELM or the EZ zone and restoration of the cost line, as you notice in the slide over there. So I'm not a stuffer. I don't like to stuff and put things inside of the holes, as we have heard from EHAB as well. And we can see here a patient that had the ILM flap stuffed inside of the hole during the surgery. And we see that even more than a year after the surgery, there is some scar tissue present inside of the hole. The surgeon will consider this as a closed hole and as a success, but the visual recovery in this kind of cases will be extremely low. So we prefer to reconstruct the different layers of the retina in the macular hole surgery. So how do we came up to this technique? Actually, in '94, we presented this tapered shaft 30 gauge micro endodrainage needle, as we call it. We presented the first 40 eyes in the American Academy using silicone oil combination with this micro endodrainage needle, and we got good success rate of all our cases. This is an updated actually prototype which we make with the Catalyst company. And we also have the completely metal tip. It's actually a 34 gauge needle that can be connected to active aspiration to close the holes. We did a study in the 90s to compare visual acuity in silicone oil filled eyes using this micro endodrainage technique compared to a gas tamponade, and we saw that we had a similar outcome in these techniques, but a better visual outcome in the eyes that we use the silicone oil. Here we see the intraoperative pictures in the beginning and the end of the surgery using this technique, and we were able to close actually the hole right away on the table. And we could prove that in another study, which we did in 2007 on 18 eyes. Actually, it was the day one OCT image that we examined, and we could see that in 15 of the 18 eyes in day one, we had complete closure and also restoration in most of the eyes of the cost line. Only those eyes, as you see here, 3 cases where the day one there was not completely restoration of the inner, of the outer retina layers. They closed in the following days after that. So we had all 18 eyes with a U-type closure. Another study that we did was about high myopic eyes which developed a macular hole retinal detachment. And the average length in these eyes was almost 30 millimeters actual length. We could achieve a 100% anatomic success rate by using this technique with a micro-ended drainage needle and the silicone oil tamponade without any positioning of the patients. So this is a kind of eyes that we talk with very large axis and also large central staphylomas. And even in those eyes, we could achieve a nice closure and a nice retinal reattachment with an improvement in visual acuity in all of these eyes, be it very modest sometimes due to the staphyloma. So the technique of silicone oil combined with endodrainage and the experience we have with the myopic macular hole combined with retinal detachment led us to this technique of retinal relocation that we published in Retina Journal 3 years ago. So I will show you the picture. Here is a case that we perform first the ILM peeling around the hole. This is a traumatic macular hole actually. Explosion trauma, and we peel the membrane around the hole. Then we will put a small bubble of decalin on top of the hole to cover the hole, and we will inject with a 40 gauge needle. We will inject subretinal BSS to detach the retina around the macular hole which is still covered with a decalin bubble. After created this detachment in 360 degrees around the hole, we do air fluid exchange and aspirate the decalin on top of the hole. And in the same way, we try to aspirate the subretinal fluid without touching the edges of the macular hole. Then after that, we will inject silicone oil, as you can see here in the picture. And we use this micro-ended drainage needle to finalize the procedure and to approximate the edges of the hole. This is also being demonstrated with EHAP in his drawing that he showed. And we see in the end of the surgery, we have completely approximation of the holes. I'll show you quickly a few cases of this high myopic eye that had been previously operated with ILM peel and gas tamponade with almost 700 microns macular hole. I'm not going to show the video here in the interest of time, but we see here the preoperative OCT of this patient, rather flat edges, and the silicone oil filled eye, which allows you to make very nice OCT soon after the surgery. The preoperative visual acuity was finger counting, and 6 months after he had 2 on 10 visual acuity. This is another case, -12 myopic eye, also previously failed vitrectomy with ILM peel and gas, and almost 1500 micron macular hole, as we see here. I will show this video very briefly. We extend the ILM peel, which had been performed in the first surgery. Then we put a decalin on top of the hole, detach the retina with the subretinal injections of BSS around the hole, perform the air fluid exchange, drain the subretinal fluid as well very carefully, then inject silicone oil as done here, and then repeatedly aspirate. This is in a passive aspiration, but again, we now do it also sometimes actively. But passive aspiration allows you very carefully to approximate. It takes a while before all the fluid is being removed in and around the macular hole, but you can close the hole on the table. Again, this is the pre-op picture, and this is the day 1 post-op picture you see with restoration of the hole. Also, a few weeks later, you see the reflex of the silicone oil in the fovea, and also there is a beginning of restoration of the ellipsoid zone. This again is the picture left in the beginning of the surgery and right at the end of the surgery, where the hole could be completely closed. And this patient particularly regained visual acuity to 5 on 10 at 1 year follow-up. Another hole in this case was a 12-year-old boy, was trauma by football in the eye, also been operated previously, as you can see here elsewhere, fortunately, with silicone oil tamponade. You can see the reflex of the silicone oil meniscus and a flat macular hole, which is, as you know, the most difficult to close, and that's why we like to detach the retina in these cases, to relocate it, to give you more possibility to close the hole. This is the beginning and the end of the surgery, the picture. Again, this is the OCT 1 day after the surgery. You see that the silicone oil is not really touching the macular hole, and it's my experience that it's not really necessary, that it's enough to reduce the turbulence of the fluid around the hole to have it closed. And we see that there's also already a nice restoration of the coastline in this OCT. Improvement of visual acuity to 3 on 10 at 6 months follow-up. Another trauma case, as you see, quite complex, irregular structure of macular hole. That was the case, and you see this is the OCT immediately post-op. Very bad picture because the corneal quality was also very bad in this polytrauma eye. The visual acuity improved, of course, very modestly in this severely traumatized eye. This is a second recurrence of a macular hole that was closed for a few months and reopened. We used our technique with, again, a good anatomic recovery, and actually the better visual recovery after the second closure of the macular hole in this technique than the patient had after the first closure of the macular hole. The same in this patient with the bilateral chronic macular hole in an older patient. We used our technique and we could reconstruct the coastline also in this patient very soon after the surgery, with an improvement of visual acuity to 3 on 10 after 4 months. And now even at 1 year, she has more than 5 on 10 in this macular hole. So these retinal relocations, as we see, we have a follow-up actually of more than 6 months average. And we could remove the silicone oil at 3 months in all of those cases. And we had very little complication rate in these surgeries. No PVR and no secondary redetachment, with good recovery of visual acuity on the average. So I think that the retinal relocation is a viable alternative for large macular myopic or recurrent macular holes. And we have limited surgical complications. And I thank you for your attention now. And I'm free to, available to answer any questions.
Thank you very much, Prof. Karl Klaus. And I have seen with you some of the macular hole that get closed on spot by silicone and sucking the fluid from the hole. But my question is how you can keep it open. I mean, you use the back flush, isn't it, just to suck the fluid from the macular hole?
Yeah, this is this micro endodrainage needle. We use the regular back flush needle to aspirate most of the fluid and to dry out the retina around the arcades, let's say. So when we have only minimal amount of BSS left underneath the silicone oil bubble, then we pick up this micro endodrainage needle to finalize the surgery actually. And then we will drain within the hole and around the hole. And this flux of fluid that is coming through the hole will attract the edges of the macular hole and give a tendency to close the hole. But it is a maneuver that has to be repeated usually a couple of times and can take several minutes before you really get a good closure. Sometimes you see the edges approximating, and after a minute or two, it releases a little bit. And that's the moment that you have to repeat this maneuver until you really, the edges remains close together.
Okay, well, I have tried with a back flush, which is work nicely, but I have to take it out, close the hole, clean it in the water, then put it back again and try to because the silicone sometimes go inside the back flush and block it for you. It goes.
You have to repeat and you have to clean it. The reason why we don't use the regular back flush needle is that you actually, the tip, in my opinion, is too large and covers the hole completely. So the danger exists, especially if you work under higher pressure, and that's what I avoid all the time, to increase the pressure inside of the eye. I work under very low conditions and use passive aspiration. But if you engage with a large backflush needle, the edges of the hole, you will enlarge iatrogenically the hole. And you can damage also the pigment epithelium because you have not a good visualization of the macular hole. That's why I like to use the micro tip, which we now when we use 34 gauge tapered shaft, and we have an excellent visibility under silicone oil, and you can avoid the damage the pigment epithelium and the edges of the hole.
Okay, so can we say regular backflush should be passive and microneedle should be active?
Oh, I use the microneedle also passive. It works, and it is if you engage the retina and you have actually low pressure inside of the eye, I mean low silicone oil pressure, then you will disengage very easily. If you have high pressure or if you have active aspiration and you would inadvertently engage the edges of the hole, it's very hard to get it out of the tip, and then you can create larger breaks than where you started from, and that's not the idea.
Okay, thank you very much, Prof. Karl Klaus. Now we will shift to Professor Ramzi from Turkey.
Good evening.
Good evening.
So, dear moderators, first of all, I would like to thank Dr. Abdullah for inviting me to this webinar. It's a pleasure for me to share my experience with you. So I have no financial disclosure. Before start to present my case, I would like to give brief information about inverted flap technique. As you know, first is described 2010 by Michalewski et al. As a multi-layer 360-degree inverted flap technique. Then different modifications have been published, and one of the group is insertion technique, and in this technique, the ILM peeled around the macular hole and insert and click into the hole. And the other one is recently a single layer inverted techniques, a different quadrant inversion, but temporal inverted flap became more popular. And in this technique, ILM is invert or the macular hole as a single layer. So in my case, I will present several cases with different etiology and challenging macular hole cases. In all of these cases, I focus single layer inverted flap technique. In all of this case, I use single layer inverted flap technique, and I will share the details and tricks with this technique. The first case is failed macular hole. We can apply this as even a failed macular hole. 63 years old female, vision loss on the right eye for 8 months. Vision is 120, and the past ophthalmic histories on successful macular hole surgery 4 weeks ago. When his doctor suggests a second operation, the patient applied to our clinic. And the pictures after the first surgery is over 600 micron macular hole. And for these patients, when we see the patient, if there is no information about the previous surgery, you can guess something. But in my technique, the best method to see what is in the vitreoretinal interface, what happened, what's the size of ILM peeling area, is AMFAS OCT. In this OCT, you can see some traction minimal retinal proliferation here, but here around the hole, you can see some dark holes as a dimples around the hole. So you can guess that the size of the ILM peeling area around the hole is this area. And then in this patient, we decide to apply this inverted flap technique because the closest area of unpeeled ILM is superior nasal quadrant, and we try to create a flap, ILM flap, and or the macular hole. So usually in my technique, I used to use small bubble of PFCL to close the hole during staining for the toxicity, but recently I use more larger PFCL to only stain the flap edge. So after you use usually brilliant blue. So when we remove the dye, you can see exactly the same area. Is the peeled ILM area, is unpeeled ILM area. This is the closest area. So we will create a flap here and is make upside down on the macular hole area. So when I make a crescent of ILM peel, then try to peel ILM is a single piece without tearing, and until the age of the previous ILM peeling area. And after this stage, I use PFCL bubble to attach the ILM over the macular area and to make a temporary attachment. Then I pay attention to peel the inverted flap, the single layer without any wrinkling, and then fluid air exchange apply. And this is 3 weeks after surgery. You can see we perfectly close of macular hole. Also the external limiting membrane and also ellipsoid zone is not completely, but is really recover, and there's small defect area, but just after 3 weeks, and vision improve 23rd in this patient. And again, on fast OCT, we can see perfectly the flap size and surface is smooth flap. There is no wrinkling in this area. So this single layer inverted flap is really helps to close this such a large macular hole. This is also geography before surgery, and after surgery, you can see the foveal avascular zone became a normal appearance. This is another case. This is the diabetic patient, full thickness large macular hole, 23 years old, type 1 diabetes, severe visual loss, almost 10 months, and just one eye patient, and best corrected visual acuity is hand motion. And the picture is this, and there's large hole, and OCT, you can see the hole, and there's strong traction of the edge of the hole, and also the dragging of the hole through the optic nerve. So in this patient, we apply combined surgery. After cataract surgery, we focus the vitrectomy. After co-vitrectomy in such patient, first I remove the connection of the membrane on the posterior pole to the anterior with cutting the edge of the hole, also partial detached vitreous, and then I focus the macular area before cornea is getting edema and blurred vision. There is a very strong adhesion, and therefore use scissors. And then this is my technique. Recently, I use large bubble to only stain the edge of the flap, not the inner surface of the flap, because of the toxicity. Because in these patients, when we invert the flap over the macular area, usually this stain area cover the macular hole if we stain. But if we stain only the edge, the inner surface of the ILM, which cover the macula, is not stained. So we lock this dye in this technique over the macular area. So maybe in long-term duration, it may cause some potential toxicity. Then again, use PFCL bubble to keep the flap dry and also temporarily attached during the whole procedure. Then remove the membrane vitrectomy probe, and then do laser. Again, do fluid air exchange. Just immediately after fluid air exchange, keep the patient's take the patient's face down position. This is one of the treatment, and this is 4 weeks after surgery. And also before and after surgery, you can see the macular holes closed. So there's some defect on the macular area, but vision improved to 0.3 in this patient. This is another patient, 62 years old female, with complex retinal detachment, giant retinal macular hole or tear. I couldn't decide. It's maybe it's iatrogenic tear, and you will see now is again it's 3 years ago cataract surgery, 9 months ago it's vitrectomy siliconoid tamponade, and 4 weeks ago siliconoid removal, and just after the removal, retina is detached and referred to a patient in our department with this picture, and you can see there's a large macular tear or hole on the macular area. So in such patient, not only the macular hole, also the treat the retina is another job because of the severe PVR. So first I remove the membranes on the posterior pole, then I reattach the retina with fluid air exchange, and I remove the subretinal fluid from large macular hole, but just keeping the fluid middle over the optic nerve. It's far from the hole because the hole is large enough to remove all the fluid. Then after PFCL bubble, again, do the same technique, stay in the edge of the hole, and first remove the epiretinal membrane, then again create a temporal crescent. Usually prefer temporal inverted flap, but sometimes we may need another quadrant flap also. Again, pay attention to cover the macular area with ILM flap is a single smooth layer to prevent the insertion of ILM into the hole, because I believe that if we keep the whole area free from ILM, it may provide better regeneration of the retina and better functional results. So in such complex retinal detachment, you see many membranes also with compressed vitreous on the vitreous space, and then do laser and apply silicone oil tamponade in this patient. And this is 2 months after silicone oil removal, the pictures, but this OCT is just a week after the first surgery. You see the reflectance of the silicone oil. The hole is flat open, closed. This is 3 months after first surgery. The hole is almost already, it is completely closed. Also, we observe significant improvement of external limiting membrane ellipsoid zone. And this picture is OCT is 2 months after silicone oil removal. You can see some glial proliferation, but when we think about the size of the hole, it was more than 1,000 micron. So the recovery of ellipsoid zone is really really good for this patient, and vision improved 20/100. So this is my last case. I applied this surgery in a lamellar macular hole also. This patient with diabetic patient, a retinal membrane and a lamellar macular hole, and loss of vision for almost 1 year, 20/200 vision. And OCT, you can see chronic macular edema, retinal membrane and traction, also a large cyst and a lamellar macular hole on the macular area. So in this patient, again, after vitrectomy and removal of the posterior hyaloid, and also remove the membrane or the optic nerve, major vascular arcade in the macular area, then stain the ILM with the same technique. But we noticed that only the nasal part of the macula is stained, but not the temporal one part. And I stained a second times if to sure that if there's any ILM on the temporal part, the same picture again. So I think we peeled the ILM on the temporal part of the macula already during membrane peeling. Therefore, I decided to apply a nasal inverted flap in this patient. Again, the same technique, use PFCL bubble to stabilize the ILM. So this stabilized flap also make a temporary attachment, and during fluid area exchange, it's really not flood the flap and backward positions. So this is 4 weeks after surgery, different section. You can see perfectly close the hole, and also almost complete recovery of ellipsoid zone external limiting membrane. So comparing the previous pictures is really acceptable, and vision improved to 20/30. So ILM flap technique, insertion technique, a classical multi-layer technique, especially insertion technique. The ILM is clicked into the hole, and also into multi-layer classic technique, the ILM may go into the hole, enter into the hole, and however, this ILM layers and also glial plaque formation into the hole may impair the reconstruction of ellipsoid zone and external membrane during macular repair. And as you see here, and this may affect the functional results. In peeling technique, we obtain good anatomic results, but not good functional result. And therefore, we should keep the whole area during closure rate is free of vitreous, free of other materials. So Iwasaki also report the case insertion peeling technique is with no recovery of ellipsoid zone and external membrane with despite the high closure anatomic rate. So in a single layer, usually we cover the macular is a single layer. Then this area is keep free. So this creates a breach between the edge of the hole, also provide vitreous-free medium into the hole, and also determine the front limit of glial proliferation. And therefore, in this patient, after surgery, you can see perfectly macular configuration is complete recovery. And I think comparing the other eye of the patient is almost hardly possible to define which eye is already operated or not, and with this technique. And what are the surgical tips and tricks in this technique? The main precaution is in order to obtain a smooth folded flap during the after surgery is use a drop of perfluorocarbon liquid during surgery to fold the flap, to keep the folded flap as a single layer during surgery, and to stabilize the folded flap during the fluid air exchange, and also perform fluid air exchange slowly and carefully. Make sure you remove all the fluid before removing the PFCL bubble, and also ensure immediate and strict face down position after surgery. Therefore, local anesthesia in this patient is preferred instead of general anesthesia. So in conclusion, single layer inverted flap technique could be the best option for the treatment of challenging macular hole cases as a primary procedure. I just note again, as a primary procedure, we should choose this technique. But even in some cases, in failed cases, as I show you, if the size of the island field area in the previous surgery is not so large, we can prefer this technique again to obtain better functional result, at least in my experience. Thank you for your attention.
Thank you, Prof. Ramzi, for this nice presentation. And we have questions actually for you. One of them is how to prevent PFCL from going through the hole, because sometimes you use it, maybe when there is no retinal detachment, it's easy, but whenever there is a retinal detachment, do you have any tricks?
So for the PFCL to go under the retina from the hole, it's not possible. You usually observe this in large retinal tears, if there's traction around the tears. But on the macular hole, I never observed these complications because it's very small, or it's not hardly possible to for the PFCL to go behind the retina in macular hole, I think.
And the staining, do you stain under air or just with the PSS?
Yeah, just PSS, not under air, because but during staining, the trick, I close the infusion in 23 gauge system, because in the 23 gauge system, even if valve trocar, there is a turbulence in the eye. But in 27 gauge, the turbulence is much less. In 27 gauge, I do not close the infusion, but in 23, I close the infusion, inject the dye, and during 40 seconds, like 1 minute, keep infusion off. Then I remove the dye as much as possible, then open the infusion. So therefore, I prevent the turbulence, and the dye may stain on the macular area and stain easily. We don't need air fluid exchange and other air staining.
What type of stain you use? Because it has to have a density sinking down.
This is brilliant blue from
Brilliant blue.
Yeah, brilliant blue from. May I say the company name?
It's sure, it's for everyone.
It's dark. It's from dark. You know, it's dual blue, but also there is a brilliant blue. I prefer brilliant blue for island peelings, or also if there's membrane, I prefer dual blue.
Thank you very much, Prof. Ramzi. Now we'll shift to Dr. Khalid Al-Sabti from Kuwait.
Hello, Abdullah, and hello, everyone. First of all, I would like to thank you, and I'm very happy to be here today with you in the webinar, and among very esteemed faculty discussing the macular surgery. Basically, I don't have full presentation. I have just 2 videos that actually summarize what everybody has already talked about macular surgery or macular hole surgery. So you will see a lot of overlap between our technique, but maybe with a little bit of differences. I just want to emphasize that macular hole surgery now, as I think everybody agrees, that we have basically multiple options to do a surgery, whether it's a primary hole or recurrence hole. Compared to maybe 10 years ago, we did not have that option. So I think the surgeon should be aware of these options and choose the option reasonable for their particular case. So whatever works for one case may not work for the other case. And I think that with experience, a lot of people will realize. So basically just these couple of videos, as I said, will summarize what we have said. Do you see my video?
Not yet, really.
Not yet.
Okay, now? Our surgical approach to macular holes depend on
We hear the voice, but we don't see the screen.
Oh, okay. Let's stop sharing and then. Our surgical approach to macular holes.
Can you share the screen, Khalid?
Okay, just 1 second. Our surgical approach to macular holes depend on many variables. Can you see it? Including size, morphology, and others. One of the described techniques is inverted island flap, which I will use in this surgery. In this video, I will emphasize how to modify your surgical technique to manage two different types of macular holes.
Khalid, did you want to make it bigger?
A straightforward small macular hole type 1, using a simplified technique in which I perform a very limited inverted island flap, just enough to cover the hole. In this type 1 hole, the edges of the hole are detached, which makes it easy to close with minimal island flap. Care must be taken during air fluid exchange not to aspirate the flap, which is very thin and fragile. During draining fluid towards the disc, ensure the correct position of the flap over the hole. Post-operative follow-up OCT showing bridging ILM 5 days post-op and complete closure 2 weeks after surgery. The vision improved from 2200 to 2050 at 1 month. The second case of macular hole is type 3. Is more challenging due to flat edges of the hole preventing approximation towards closure. In these cases, I believe an extra step is required in addition to inverted island flap, especially in large holes over 1000 microns. It may be necessary to perform autologous retinal flap or induce macular detachment, as done here in this case. Then using 48 gauge cannula, macular detachment was induced to free the macular hole edges. The rest of the surgery was the same, including air fluid exchange. At 1 week post-op, the hole was closed. Visual acuity has doubled in this case. This is Dr. Khalid Sabti. Thank you for watching. Okay, so as you can see here, the technique of ILM flap, I think everybody does it a little bit different. I realized that we don't need to do a large ILM flap. I just make it enough to cover the hole for many reasons. First, you minimize your macular trauma. Sometimes when we retry and re-grab the ILM edges of the flap, we may induce trauma. Second, we may need that ILM or extra ILM for in case if we need to do future surgery. So I thought maybe it's better to minimize your ILM flap, inverted flap, for future, and it will, I think it will give the same effect. This is for the first case. Of the second case, obviously it's very similar to what Klaus is doing. Is I detach the macula because it's a flat open and it will never close even if you do island flap. So it's just to be able to approximate the edges. I think we have to detach the macula completely and let it reattach again where the edges of the holes will be approximated to each other. So this is my first video. I don't know if I need to answer a question now or should I go to the second one?
The second one.
Okay. Good, so let's share. Can you see it?
Yes, you can play it, please.
Okay, so this is just to address the question how fast the hole can close, and Klaus had showed that one day. In the literature, it's usually between 3 to 5 days. This is a very particular case. It is a giant retinal tear detachment with a macular hole. And I thought this is probably, it's going to be different because you will have a lot of, from the giant retinal tear, a lot of tangential forces released because of the GRT. So I didn't want to be very aggressive in this case and to go as traditional as before. Instead of doing ILM flap, I did just 360 ILM peeling, which I think retrospectively, probably without doing it, the hole might have closed. So what I do just routinely, I flatten the macula so the stain does not go in subretinal space. And then I did just a very simple, straightforward 360 ILM rexus. Of course, doing it in a detached retina is a bit challenging, but you try to be very careful not to traumatize the retina, the macular area. And here I flattened again because it's a detachment, and I did the rest of the surgery was like the routine GRT laser to the giant tear, and I did 360 also. As you notice that the ILM rexus here was not too large. In case for future, if you need to go and reoperate again, you need an extra ILM for future. But I was thinking to do the inverted flap or not, but it seems that I decided to do the right thing, not doing it. This is of course silicone oil. What is surprising to me that it's less than 24 hours, the hole was completely closed by OCT, as you can see here, with the normal structure of the fovea is regained without anything, any more intervention is needed. So basically this, I just wanted to, I think this is gonna recap what others are saying about macular hole. And I hope this would give a lot of impression to what we should do and how to direct our surgical approach as per the cases. So thank you, Abdullah, again for the invitation, and glad to see all my friends here.
Thank you very much, Dr. Khaled. Before we give you the question, we have a poll that we're gonna run it actually. So I need from all the audience and attendees to participate in this poll, please. The question saying, if you have a macular hole and you put gas, how many days you keep face down in the macular hole? We will have 25 seconds. I see the majority between 2-3 days options and 1 week option till now. Okay, so we will stop and the poll. We will share the result so you can see it. 3% they don't recommend face down. 2 to 3 days is the maximum by 46%. 1 week is 42%, and 2 weeks is just 9%. So the majority, we can say like 88% prefer between 2-3 days and 1 week. This is the question to you actually, Dr. Khaled. How many days you keep face down?
I usually 1 week. I don't exceed 1 week. As I said, the hole usually closed by 3 to 5 days, but I prefer, because you cannot be sure, and you know our patients, the compliance of the patients is not like in Europe or US. So when you tell him face down, he just does it for 10 minutes a day. So yeah, I'd rather have him a week rather than 3 days. If he's strict, I think I can do it shorter.
We admit all that face down position is more tiredness for the patient than the surgery itself. You agree?
Yeah, of course.
Okay. I think we are very grateful to you, Dr. Khaled. We will shift back to Prof. Ihab for the complication, please. Then we will have discussion after.
Well, this part of the presentation is open for discussion while we're doing things. Now, we saw beautiful surgeries before, so let's see when things go wrong during surgery. This is a patient first, if you can all see it, I'll increase the screen there. I'm sorry for that. There. This is a patient that had a macular hole, and you can see that during the surgery, I tried to keep it foveal sparing and leave the fovea till the last part. While doing the ILM peeling, they're trying to save the ILM over the hole right there. The extension of the ILM flap came to an uneven part right here, trying to keep this all as one piece. So one of the problems that happens is hemorrhage. We know that hemorrhage can happen if you have direct trauma, but this is another type. This is the last thing there, the ILM there removed. I don't like grasping the ILM over the papillary macular bundle. This is mistake number one. Grasping over the papillary macular bundle, you could damage that area. This is a different type of hemorrhage. These are particular hemorrhage, or you can have direct hemorrhage. But look at this one. What is this type of hemorrhage? This is inner lateral decompression hemorrhage. It's a whip-like effect. When you pull the ILM and release it, all of a sudden, the inner lateral capillaries can blow out. So let's see this hemorrhage happen here. You ready? I remove the ILM. Look what happens when I release the ILM. There. It starts to bleed. So this is not a direct injury, but this is a recoil or a whiplash effect that happens due to recompression or whip-like effect that happens to the inner retinal capillaries. Let's ask the panel, how would you manage something like this in a case of a macular hole? The question goes to Carl maybe first. What would you, Carl?
Thank you, Ihab. I think I would try to manage like any hemorrhage first by increasing a little bit the pressure, since it is usually not a very large vessel that is breaking. The pressure should not be elevated too long and too much. We could use some of the blood actually to fill the hole with, which we know the platelets can help us in closing the macular hole. But I don't think this hemorrhage would be too much of a problem during the surgery.
I agree totally, because this type of hemorrhage is different from the neovascular vessels that happens and we need to increase the pressure. I did increase a little bit, but look, there is no pulsation at all. There is no pulsation. So the pressure was 30. I completed the surgery. It stops by itself by time. No compression. You can see the blood vessels. There is no pulsation. Pressure is 30. Once you complete the ILM peel, you can just remove this in a minute. It does not complete by itself. It stops spontaneously. These are not new vessels, but these are hemorrhages from the inner retinal layers, and they stop spontaneously. You can continue your case, close the ILM, and you look at the end of the case right there. Day 2, you can see that the hole closed. This is pre-op, and at day 2, the hole closed, air bubbles still inside, and that's the site where the hemorrhage was right there. And at day 5, it's completely gone and the hole closed. So again, these are different types of hemorrhage that happen during ILM peeling, and we keep that in mind. Another complication. This is a case of macular hole while removing the ILM. It's a more devastating complication. So while removing the ILM using the macular window lens, it gives you very good magnification of the central area, but you lose the depth of the perception in the periphery. So under high magnification, you get a nice peel right there. Increase the ILM peel, but in the periphery, there is no depth of focus, and we have to all keep that in mind while working with contact lenses or macular window lenses. Now trying to peel, moving the forceps a little bit around the eye here. I increase this, going again to the periphery, which is the wrong thing while using the macular window. You have to always focus on the central part, trying to get rid of the ILM there. Bang, and the forceps hits the retina right there, and you have a hemorrhage and a retinal tear in the area moved with ILMP. Let's ask the panelists, how would you manage something like this? Would you stop right here, laser that tear? How would you manage something like this? Let's ask the rest of the panel.
I think again we increase the pressure to stop the hemorrhage in this patient. The defect on the retina is not very small. I prefer laser, slight laser around the defect area in this patient.
Khalid, would you laser in an ILM peeled area?
I think just control the bleeding and maybe extend the ILM that side so the hole will close. I don't think it's
already in an area that was ILM peeled.
Oh yeah, probably if it is clear on the temporal side, I will just leave it like this. I think this will close with gas. I don't think I should do laser at this point.
Abdullah, would you do something different?
Actually, in the area that ILM already peeled, I would leave it. It's rarely get detached whenever you have tear, small tear, especially on the posterior or around the macula, let's say.
Okay, the take-home message from this here is to always, when you're using macular window lens, don't forget that the resolution or the depth of focus is lost in the periphery of the lens. So the focus part is the center. Once you go to the periphery, always use low magnification or change to a different type of lens. And here we go again. That's what I did. It's already in an ILM peeled area. I just removed the ILM and I put gas, control the hemorrhage, as everybody in the panel just said, try to get rid of the hemorrhage. This is how the whole looked like before. And this is after looking to a seal, and this site of trauma, again, the hole closed, and we did not need to put any laser inside the eye. Another case, this is a case.
Why didn't you put ILM flap on the hole there?
Definitely, that's one option. You could do that, but already I was getting rid of everything inside the eye. I was scared about the hemorrhage, so I just dumped the ILM, which I got. But maybe putting it back in place, that's a nice Comet car for that. This is another case of a large macular hole. You can see this here.
Comment we have. I don't know if you can hear me.
Yes.
Yes.
Yeah. If I may add a small comment, just to differentiate between this type of hemorrhage and the initial hemorrhage that you showed us, the recoil hemorrhage, where you don't necessarily have to raise the intraocular pressure. Here, there is deeper trauma, and you can have subretinal bleeding from such an injury. And this can
absolutely right
significantly. So here, I think elevating the intraocular pressure is a must, and probably maneuvering the eye so that the hemorrhage doesn't track towards the macular area.
Exactly.
And I agree. I think these holes usually don't detach. The scarring effect is like a laser effect over time, and you don't have to laser them.
Great comment. Let's go to another case. This is a large macular hole right here. I decided to put an amniotic membrane. You can see the size of the hole is pretty much the size of this right here. This is the size of the hole. I was going to go for an amniotic membrane. Getting a 1.5 millimeter punch from outside the eye, putting it inside, it looked very big inside. So I decided, see how large this amniotic membrane is? So I decided to trim it a little bit, make it a little bit smaller. The challenge again, put it back in place. The challenge is how to keep the ILM in place. This is under PFO. So again, once you go to fluid air exchange, sometimes you get dislodgement. Key features, if you use a very large piece of amniotic membrane, larger than the size of the hole, usually you get displacement whether you put it on either side, because usually there is no entrapment and the friction over the retinal surface, they tend to move. So this is the first mistake, taking a big flap on a moderate size hole. This is what happened. I left that in place, and the second post-operative day, the amniotic membrane was not in place and the hole was opened again. So this is a large amniotic membrane over the mass, larger than the size of the hole. Removed the perfluorocarbon bubble, went to gas, and looked at the patient the second post-operative day. The amniotic membrane was not in place. What did I do? So I take the patient again back to surgery, and this is the part of the amniotic membrane inside, and the hole was open. It was dislodged inferiorly. This is the second surgery. That piece of amniotic membrane is inside the eye, and you can see I'm just cleaning any residual matter. There's the hole again, and you can see that the size of the amniotic membrane is larger than the size of the hole. So I retrimmed it inside the eye again to a smaller piece, try to fold it first, and you see that the sticky part always grips to the instrument. So it's not a fact, trying to put it right here, it sticks to the instrument, since you already had a larger patch. The undersurface and the oversurface is something to keep in mind if it's fresh. If it's not, you lose the sticky thing there. It sticks to the forceps. That means it's going to dislodge again. So I decided to cut it again, trim it to a smaller size, and put the sticky part over the retinal surface like a stamp over the macular hole there. Perfluorocarbon, make sure it's stable in place. Then I removed the perfluorocarbon and went to gas and air. This time it's sticked in place, but again, putting it over, I feel that this is a bulky piece of tissue interfering with the normal photoreceptor realignment. So sometimes putting patches over the eye interfere, and you can see this is as early as the first week. It is really a big patch inside the eye. So how do you keep patches inside the eye? Let's ask the panel. Whoever uses patches, ILM, whatever. I know that, Ramsey, you like to keep it hinged flap so it doesn't dislodge, but you never saw even the hinged flaps go up and down inside the eye. And how do you do tricks to keep it in place?
Actually, I do not have experience with amniotic membrane transplant.
I mean with ILM, did you see your technique with ILM flaps?
In ILM, I use PFCL bubble to make attachment during surgery, like 10-15 minutes, and PFCL bubble make a temporary attachment between inverted flap and the retinal surface. And then during fluid area exchange, even I remove all the PFCL bubble and still there is some fluid, but the ILM is not reinverted again. And I think PFCL helps us to make a little attachment of the inverted flap during surgery. And then the other trick that we should really keep the patient strictly face down position after surgery. Even when I finish the surgery, I change the phase of the position of the face of the patient's face, like through the nasal part of the eye. If I operate the right eye, they turn the face's nasal to the left, and this means that fluid accumulates in the nasal part of the posterior pole during the other rest of the job, and then turn the patient same position to the upside down. And this is, I think, the trick that otherwise we consider floating ILM after surgery. But if you keep this strictly face down just after surgery, this helps us to keep the inverted flap in place.
Does anybody in the panel use free flaps, free ILM flaps?
Yeah, I have used.
Please, Nicola.
Yeah, I have used free flaps in the past, Ihab. I don't like hinged flaps a lot because sometimes they do contract and they can lead to recurrence themselves. So I used to use free flaps, and I've tried several tricks in the past. I've used viscoelastic on top of the flap. I've used blood, hoping to form like a scaffold around it so that it sticks more. But really, it's very difficult to keep it in place. I think the most important maneuver is the way you do air fluid exchange at the end. And I do this under very, very low pressure. I go down to 10 and lower, and I aspirate actively, not passively, so that I can control the aspiration. And I use very low aspiration rates. And I start from the top going down. I don't go close to the nerve the way we usually aspirate. I start from the surface of the fluid, going down, down, down. That way, the bottom part of the fluid doesn't move. There is no turbulence when you're sucking from the top, from the surface of the fluid. And then the last bit, I turn the eye so that the gas bubble opposes the macula and the fluid moves gently towards the nerve, and I suck the remaining bit. I have to admit that no matter what you do, there is a risk of the flap dislodging, but I feel that this air fluid exchange maneuver increases the chances of it not dislodging.
I just have one comment again, or actually it's a question that goes to Kara and Khalid. I saw the hydration technique. It's a very elegant technique, and I know it stretches the retina. It gives you a little bit of retinal elasticity to close the holes. The difference is I saw that Kara does a very good thing. He plugs the hole because you don't want the fluid to go out of the hole while you're hydrating or stretching the retina. So is there a difference in this technique? Carl, I know that maybe that's behind why you put a perfluorocarbon bubble over the macular hole.
Yes, of course. I mean, once the subretinal fluid finds its way through the hole in the vitreous space, the bubble will not grow to the periphery anymore. So we need to plug the hole with a decalin bubble in order to get more peripheral detachment and more surrounding 360-degree retinal detachment. I think that's imperative. Otherwise, you will not succeed in freeing up the surrounding area around the hole, and especially the edges of the hole need to be free 360 degrees, and that's sometimes the most difficult part.
So I turn the discussion back to Abdallah.
Thank you, Prof. Ihab. I will just show you one video. Can you stop sharing? Okay.
I already stopped sharing. I can see your screen now.
Thank you. So I would like to show you this video and take your opinion regarding this difficulty. This is a combined surgery. We don't need to see the cataract. Of course, we all put the trocars before the cataract surgery. Do we all agree? Prof. Ihab, do you put trocars before cataract in a combined surgery?
No.
Well, now really I put them because I don't feel that they interfere with doing the phaco, so I put them before. Yes.
At least infusion, at least the infusion, maybe.
The infusion without opening the infusion. It doesn't make a difference even if you put all three of them.
Okay. So this is the cataract done. Then we will go down for the vitrectomy, and in that case, after staining, removing the vitreous, unfortunately, there is some remnant of the cortex above the macula. Maybe we all see it here. So I think maybe we can, yeah. So how you can remove it without, of course, diamond scraper is easy to do it, but if you don't have diamond scraper or silicone tip, how you can remove it, Prof. Ihab, in advice?
You mean for the PVD?
For the cortex of the PVD, yes. Cortex remnant of the PVD.
Well, usually you can do it by the vitrectomy cutter by itself. Just gentle aspiration at the upper edge of the disc. You can actually detach it. And sometimes, as you just mentioned, if you can't do it, sometimes you might even need to do it mechanically or grab it by a forceps or just by a pick. The turbulence of the fluid, by time, if you keep doing a vitrectomy, the fluid itself finds its way and pops it off the retinal surface.
I'm not talking about the BVD on all. I'm talking about a small island of cortex remnant of the vitreous over the macula only. So
yeah, you can still do that just by the aspiration. By aspiration, yeah, it pops off by itself.
And do you agree the small gauge is easier and better than the big gauge in this technique, or no?
With the closed system, I think that since now it's a closed system, so this makes the suction directly at the tip and more concise. So it acts also as a forceps. It's more controlled doing such a step.
Okay, at least in my hand, forceps and trying to grasp the cortex is difficult because it's fragile and it's cut it frequently. And even with the tip, this case is 23 gauge. So I don't have, unfortunately, neither Finis loop at that time was out of stock, and neither the silicone tip. So I decide to build a silicone tip by my own. So I try with the vitrectomy tip, as you see here, but it doesn't open, actually, it doesn't detach. So I cut a cannula, small cannula, just a small silicone round of the cannula. You should always try to make it thin as much as you can to become able to introduce it, and keep it long as much as you can because you need the curve of the silicone tip. Then with that silicone tip, with the forceps that you grasp it with, you can just scratch the cortex remnant and take it away. Then you can complete it with the vitrectomy. Actually, sometimes I use it even to open the flap of the ILM if I need some dissection whenever I don't have any silicone tip or Finis loop. This is my part. Maybe we can go for Dr. Ramzi for your PFCL under the retina. Do you still have the video?
Sure. Can you stop the share screen, Abdullah?
Yeah, I did.
Okay. Think. Yeah. So this is submacular PFCL bubble referred to our department with this complication. So you can see the two bubbles. One is on the subfoveal area, and the other is temporal part of the fovea after retinal detachment surgery. And in OCT, we can see the bubbles, the multiple bubbles. But again, on fast OCT is perfectly show all the bubbles, small and large, and size of the bubble. In this patient, there's 4 bubbles, and we missed with OCT one of them. And then apply surgery. Again, multiple PFCL bubble still remain in the vitreous cavity. When we remove this bubble, the cause of retinal detachment in this patient, this is AMD patient, and retinal detachment developed after intravitreal injection. And the same surgeon applied the retinal detachment surgery, and then this complication referred to patient as that. So in this patient, I usually use 41 gauge cannula and give BSS injection and make a retinal detachment on the area, but then I bend the 41 gauge cannula to reach the PFCL bubble in this detachment area, because it's really dangerous to go directly into the PFCL bubble and aspirate it, because it's very small bubble. But with this system, it's at least in my hand, it's much safer, and you can so perpendicularly, and you can remove the bubble and from far fovea. Again, also for this, the other bubble, I will use another way to go there, but I inject more BSS and detach the retina, then go from this part to foveal area and aspirate the bubble. So the BSS injection in this patient is really important to define any rest of the bubble in this patient. And this is after surgery. You can see the pictures, and this is OCT. Perfectly see the bubble is already gone, but on fast OCT, yes, the fovea is okay, but on the temporal part of the way, there's still small bubble of a piece of PFCL bubble. So this is the end of this case. In this technique, in this patient, I prefer aspirate the PFCL bubble after the BSS injection and detaching the retina or the macular area.
Hey,
so I think, Rimzi, if it was just one bubble, I would directly aspirate it, especially if it was an area of an ILMP. If you aspirate directly over an ILMP area, you could directly aspirate the perfluorocarbon if it was one bubble. But since in your case it was multiple bubbles, then I think hydrating the retina and trying to get them all in one quadrant and aspiration is a very good option, as you just saw. So it's a big difference between having just one single bubble in the macular area or subfoveal area, or having multiple bubbles like you very nicely showed in your case.
Do you laser it?
Especially,
do you laser it? Do you laser it, Prof. Ramzi?
No laser, because it's very small retinal defect. If the bubble is placed on the fovea, it's really dangerous with direct aspiration, because you may create a macular hole in this patient. So also you may touch to the RP on the foveal area during this direct aspiration. Therefore, I don't like to make direct aspiration in case that the PFCL bubble is on the fovea, just on the fovea. It's also of the fovea, you're right, you can be right. But on the fovea bubble, I usually prefer this technique, and from around the macular fovea, I go under the retina, and perpendicularly, I remove the bubble.
And good thing about hydration also.
Make a remark?
Yeah, please, Prof. Carl.
Yes, I would also detach the retina as very nicely shown elegantly, and then I would try with a soft tip to see if the bubbles can be mobilized in the detached area of the retina. And because sometimes they're encapsulated, especially if they are present for a longer time. If they're mobile, the bubbles, then I just leave them in there, and I put the patient upright, and the bubble will go down to the arcades inferiorly. And you don't even have to remove them. You can leave them there, and the retina will flatten automatically in 24 hours or so. And you don't need to make any danger by doing subretinal maneuvers in the foveal area.
Sometimes it's maybe even safe to leave it there if it's paramacula and it doesn't disturb the patient.
Exactly, but I talk about subfoveal, and you can mobilize them by gentle massage or by injecting epiretinal decalin. Actually, I described this is published in Steve Ryan's retina book, where I made this video. You can inject decalin over the subretinal decalin and push it towards the periphery, and or leave it or puncture it in the more peripheral area where you absolutely have no danger of any visual impairment.
Usually this happens if they were early, Carl, you agree? If they were there like 2 or 3 weeks, usually they're less likely to move unless you inject BSS underneath the macula.
No, but it is after the injection of BSS. You detach the retina, but then you reattach it by another bubble, and you steamroll actually from upside to the inferior part, and you can push the mobile bubbles towards more peripheral area, where you can make or a small retinotomy with a 40 gauge needle, or you can just leave it and put the patient upright, and the bubble will stay there, but in an area that doesn't disturb visual acuity.
Carl, you agree? I agree with you, because sometimes it's hardly possible to be sure that you remove all the PFCL bubble under the retina. So you cannot be sure. Then your technique could be really good because you move the rest of the bubble from the macrofoveal area. So it's really good idea to, with a large detachment. So I think you create a detachment, almost reach to major vascular arcade, and then do this maneuver. So this is good idea.
Exactly. But very small bubbles are hard to visualize transretinally, you see. Yeah. And then you cannot be sure that you have everything. But if the bubble is of substantial size, it's really easy to do in this way.
Thank you. We have one of the question raised his hand for talk. Dr. Muhammad, you are with us, Dr. Muhammad? Can you hear us? Can you unmute yourself if you're still there? So he's already unmuted, but he is not there. A question for you, Prof. Carl. Someone asked how many the hole get open after you remove the silicone, and how much the duration that you keep the silicone inside the eye for the big macular hole?
For the big hole, I used the tamponade for 2 months, 6 weeks to 8 weeks actually on the average. And actually, you don't see reopening of the macular holes. As you see on the OCTs, there are very nice reconstructions of the different layers of the retina, and I never experienced secondary reopening after removal of silicone oil.
Thank you.
Do you have any indication about the size of the macular hole for silicone oil tamponade? What's the minimum size of the hole, like 1,000 or others? Do you have any defining like that?
It depends. Sometimes I use silicone oil without relocation. That means without detaching the retina, just using this micro and the drainage needle. And I do it in those cases from 500 microns and up, let's say. But it depends. If it's a myopic patient with a staphyloma, I will use easier silicone oil. If it's a recurrent macular hole, I will easily use silicone oil. If we cannot put air or gas in these patients for one or other reason, I will put silicone oil. If it's a child, like the boy that I showed in the presentation, 12-year-old boy with a large macular hole after the trauma, then I will use silicone oil. So it's not only the size, it's also the duration of the macular hole. Is it the flat edges of the hole? There is multiple factors that are involved in the final selection of my tamponade. But I have it as a good alternative, and I can guarantee for almost 100% that I can be able to close the hole, and that often convinces the patient to choose also for this kind of tamponade, even if he has to undergo a silicone oil removal after 2 months.
Mm-hmm.
Prof. Ihab? Some of the question came from the audience. What tamponade you prefer to decrease the dislodging of the free flap? Do you prefer gas or silicone?
Well, in most of the cases, I use gas. I never use silicone in these cases. Silicone will not help because still when the patient is semi-sitting, there will be some fluid between the silicone bubble and the graft. And the graft, I think the graft is just a patch. It helps to keep the hole while healing away from the fluid inside the eye. So in most circumstances, if the healing process starts in the first 48 hours, less likely the graft is going to move. And there was one video, maybe I don't think that I have time to show it, shows the healing, then the dislodgement of the graft after the hole just healed. If you have one minute, or we're already over time.
Yeah, sure. Maybe last a few.
Okay, so I'll just share with you this video. There, can you see this?
Yes.
Okay, sorry, it's this one there. So this is a myopic hole that was operated upon, and the same thing, we decided to put an amniotic membrane there. That's the size of the hole right there. We put the amniotic membrane under perfluorocarbon, which is the best way to manipulate it inside the eye. If you do it in fluid-filled eyes, they're likely to move around. So just putting the perfluorocarbon bubble first, preparing the amniotic membrane there with the punch, and small piece inside the eye, aspirating and injecting it directly in the perfluorocarbon bubble over the hole right there. It stayed in place. I did the aspiration. While doing the aspiration, this is the thing. Once the perfluorocarbon bubble, that's the edge, starts to move, sometimes you get migration. It doesn't make a big difference if you put it on the under surface or the over surface. Still, there it stayed in place and the perfluorocarbon bubble is going away. So this was a good sign that it stayed in place. And there, it started to move. So this means that this is not stable. I reposition it again, then start drying 160 degrees, 360 all around to make sure that the last bit of bubble comes off and it stayed in place like there. I finished, injected gas, saw the patient, that's the pre-op, and the post-op, it healed. This is an air-filled eye. This was taking 2 days. The hole seemed closed, but I can't see the amniotic membrane. What happened? The hole did close, but the amniotic membrane did get dislodged and it's floating in the inferior air bubble right there inferior. So they could act as patch, just give time to the hole until the edges flatten up in place and stay there. So it's just causing the dehydration. But I don't think it shares anything in the healing process that happens inside the eye.
Okay.
Yes, I have the same picture that I showed in my presentation of the free-floating ILM flap, the temporal flap, after perfect closure of the macular hole with 10 on 10 visual acuity recovery. But the flap after healing became free-floating, and the patient is noticing this.
Okay.
Because his vision is so well recovered.
Yeah.
Thank you
Oh,
very
you were
much.
lucky.
Last question maybe for Dr. Khalid. Some of the question ask about your visual system and editing software.
Oh, I use Ingenuity for most of my cases, so it gives you an excellent high quality videos. For editing, TrueEdit is a software. You can buy it on the internet. It's called TrueEdit.
It's edit 4K also, or?
Khalid, why do you hydrate your lenses all the time?
Yeah, sure. There is another software. It's called Cyberlink. I think it's better than the TrueEdit of the Ingenuity. Cyberlink, Power Direct. It's the this is the software that I use for my editing. It takes a little bit long time, but you can incorporate a voice overlay and text, etc., etc.
Okay, if someone has something to add, otherwise.
I have one quick question for everyone regarding, we have seen a lot of macular surgeries. Does everybody use a contact lens or does everybody use the non-contact? This is a very common question that keep coming. Personally, I rarely use macular contact lens for any macular surgery. I do them with the Resight or whatever. So the question is open to the panel.
Khalid, I can answer the first. I almost never use contact lens, only rarely in macular hole cases. In myopic macular hole cases with staphyloma, it's really difficult to visualize with non-contact system. I use IBOS system in all macular surgery and all surgery. Like Ehab showed that in the small viewing area, so we can make some mistake and we can make some retinal defect and other things. Really, I almost never use contact lenses. So this non-contact system is enough, I think, sharp visualization to work on the macula during whole surgery. At least this is my experience.
If you allow me, Khalid, actually, I think, at least in my knowledge, we should start with the type of the macroscope. There is two types of macroscope. One is 200 millimeter focal length and one is 175. And this is the two category of the macroscope, whether for anterior segment or anterior segment and posterior segment. And building on that, your type of biome is going to be adaptive to the focal length that you have. So every 175 macroscope adapted to 175 biome. In my hand, after shifting to Lumira 700 with the non-contact, with the Resight system, I stopped using contact lens forever actually. And with the green lens, it's become faster when you just shift it and to control the focus easily and make the run of the work faster. But sometimes the with the wrong macroscope, you cannot push it farther than its limit. So contact lens maybe use, especially if you want to see bigger image, because as much as you enlarge the image, as much as the light become dimmer and you lose some of the density of the lights, and also the resolution building on that become less. And maybe this is why the indemnity is very helpful regarding the light density. Yes, Prof.
Abdullah, you don't have this problem if you use the Ingenuity system or Artivo. Then you have a very large image and you don't lose actually too much resolution. So I also never use contact lenses, as you know, and I prefer to use the combined biome lens, which is a combined macular and peripheral lens. And you have actually all the time, even during your ILM peeling in myopic cases, you have always overview of the periphery, which I like, because if a peripheral detachment or choroidal hemorrhage occurs, I want to know it right away. But Ingenuity allows you actually to enlarge the image. But I have to admit that a macular contact lens, the resolution can be a little bit better than with the non-contact version. And but again, with the digital augmentation of these systems, like Ingenuity, you overcome easily this small inconvenience of the resolution.
Also,
or Leica?
Abdullah, the Oculus has a lens that is you can use it for biome or for Resight, and I have tried it and actually I use it. It gives you a sharper image and very crisp image.
That's what I mentioned. Yeah, that's what I just mentioned. Yeah, the combined lens. Yeah.
Okay. Yeah, disposable. Unfortunately, they are disposable, but it better.
No, they exist in reusable as well. It's called the golden lens from Oculus.
Okay. Yeah, it's called the Lens Z. It's by Oculus. So they have a disposable version and the reusable version. I use it also. It's very good in the macular area as well as the periphery, as Carl just said. It's called Lens Z.
Actually, it's amazing how good it is, even if it's disposable.
Yeah, you know what, I have to say, like what Carl mentioned, I really think that nothing beats the sharpness and the focus of a contact system. I think if someone, in the absence of the digital augmentation, I think it gives you the sharpest view. There's no doubt about this. But one has to be careful about the limitation of the field, like Ihab elegantly presented and Carl just discussed. One has to be very careful in using it and not to work at the edge of it because of the prism effect and the potential for damaging the retina. But definitely the sharpness and the focus of it is unparalleled.
Okay.
I have one more important question. That was part of your poll actually. And we never commented on this, which is the face down positioning. Now I had internet problems. My internet was going back and forth. So I don't know if this was discussed, but I think that's an important question, and it's important for our audience to know what we do. What I would like to ask the panelists, what do they think about the face down position? Was this discussed, Abdullah, at all?
Shortly, but if you can ask everyone his duration, maybe would be, and positioning. If he start by me, I do face down for 2 days only.
Yeah, so let's see. Let's start with Ihab, for example. Ihab, do you ask your patients to position face down?
Well, for small holes up to 300, 400 microns, I just tell them avoid supine position, stay in the reading position. So during the day, they're looking like they're reading their tab. And I think that's more than enough. If you put the sulfur hexafluoride in the first couple of days, it never crosses the inferior meridian for 48 hours, which is sufficient for a hole to close. But for larger size hole, I might tell them, well, you stay face down for 2 days. So just avoiding supine position, or tell them just stay in the reading position during the day. And at night time, you have the option of sleeping on the side or the face, but not on your back. That is sufficient for me for most macular holes. Unless it's a large hole, then I might tell them stay face down.
Yeah. How about Khalid and Carl, Ramzi?
Actually, in small hole, like under 400 micron, I usually prefer face down position 2 to 5 days, 2 to 3 days sometimes. But If tumor hole is larger than 400 micron, I prefer a 1 week face down position, Ghazi.
Okay. Khalid?
1 week. I usually ask them 1 week.
Yeah. I think you mentioned that.
Yeah, because they don't do it 1 week. So if you tell them 3 days, they will do it for 1 day. So ask for 1 week, you get 3 days. That's the deal.
About Carl?
So, yeah, I agree with Ihab. I mean, medium-sized holes, primary holes, no positioning at all, just avoiding supine position for 3 days, but no positioning. You will usually put SF6 gas, and as you mentioned in the upright position, the hole will be covered for 2-3 days, and this does the job, I think.
I agree. I rarely ask them to position. I think the most important statement is not to be supine, and that's the most critical. But if you have a good gas fill and a small size hole, a SF6 gas bubble is enough to tamponade that break in that hole in the upright position for a few days, which is all what one needs for the macular hole to close. So I agree.
Okay.
But there was only 3% who answered no positioning. It depends on the size, but still there were only 3% who answered.
The 3 of us also. So
I answered that too, yeah.
I would like maybe to thank all of our speakers. We'd like to thank Prof. Ihab, Prof. Carl, Prof. Ramzi, and our dear Dr. Khalid and Prof. Nicola also. We have taken a lot of worthy time from your schedule, and thank you for accepting the participation. I would like to thank all the audience for staying with us till the end for their participation in the poll, and hope to see you soon, inshallah. Thank you very much.
Thank you.
Thank you.
thank you.